So there are essentially three processes that may happen in management of opioid use disorder. So an individual may go through what's called a withdrawal phase. This can include just utilizing supportive treatment in management of their opioid withdrawal. Can also have an induction where an individual is initiated on an agonist or partial agonist opioid product during the withdrawal phase. And then maintenance, where someone is taking a medication used for opioid use disorder treatment long term. And there's some overlap in some of these, and there's also some distinctions between these processes and these products. So there are some products that can be used both during basically a withdrawal or detoxification, and there are some products that can only be used in maintenance, and there are some that are only really beneficial during the detoxification phase or the withdrawal phase. So clonidine and lofexidine are products that can be used to help support the symptoms of opioid withdrawal, but do not offer long-term treatment for the use disorder itself. It's just symptomatic treatment. Then we have buprenorphine products, so buprenorphine with naloxone, and methadone, which can be used both if someone is undergoing a tapered withdrawal or if they are going to be induced and then maintained, okay? Naltrexone is a product that's only utilized in maintenance if we're using it for opioid use disorder. Because it's a full antagonist, it fully blocks the activity of opioids. It can induce a more significant withdrawal syndrome. So someone should be free of opioids for an extended period of time prior to initiating naltrexone. So our medically assisted opioid withdrawal, sometimes referred to as detoxification, it can be utilized to reduce the severity of withdrawal and transition typically to a medication-assisted treatment or medication for opioid use disorder. The recommendation is whenever possible, if the individual is going to be able to, go to follow-up and utilize a medication for opioid use disorder, we should encourage and offer that. But there are some scenarios where, whether it's, strong patient preference or other unfortunate resource issues, transitional issues, someone may only undergo a withdrawal. Okay. So methadone and buprenorphine can be utilized in the acute withdrawal space, as mentioned before with the previous image. They're both considered, by and large, first line for withdrawal as well as maintenance, but we've shifted more and more towards utilization of buprenorphine. It's more flexible, it's more accessible, it tends to have a safer adverse effects profile, so you're going to see buprenorphine products used much more often. We have opioid agonists that can be used throughout this process, but sometimes with an accompanied alpha-2 adrenergic agonist that are considered more in the second line and really have a supportive role in this withdrawal or induction phase. Okay, so they will help treat the symptoms, the physical symptoms, but not the condition itself. So when I mentioned induction, we kind of talked a little bit about it, but it's essentially most commonly done when someone when they have evidence that they have opioid use and they start to exhibit symptoms of withdrawal. So at a certain point, usually in the COWS scale, at a certain point, then we'll start dosing them with a methadone or buprenorphine product, okay? Most commonly, the scale is going to be somewhere between a COWS of 6 to 10 and maybe repeated in a certain number of hours and then redosed. So it could be 2 to 4 hours a lot of times. This usually will require pretty close monitoring for safety, for tolerability, and to help determine what dose, particularly if someone's going to be maintained on a buprenorphine or methadone product, what dose will be the appropriate dose for them. There's also some data to support utilization of a lower dose or like what sometimes they refer to as microdosing of buprenorphine. The most common method that's named for this type of initiation phase is called the Bernese method. And this will actually slowly introduce very low doses of buprenorphine to help mitigate the risk of precipitated withdrawal. So these are individuals who are taking high doses of methadone or have been taking fentanyl for a long period of time. Sometimes the partial agonist activity of buprenorphine, because it has a higher affinity for opioid receptors, that reduction in activity is so significant that it can cause a really unpleasant precipitated withdrawal. So there's theories that it can be more successful for those types of situations because you're not causing as much discomfort as you would if you used a traditional induction method. So when we're using medications for opioid use disorder, one of the questions that I hear is, well, how long should they be taking these products for? And the answer is as long as it's still benefiting them, as long as it is, producing an improvement in their quality of life, right? So there's no set limit to how long someone might use buprenorphine or methadone to manage their opioid use disorder, okay? So continuing after the induction period, we can keep them on those types of products long term. And it's really in the light of trying to achieve stable treatment that not only in the short term suppresses withdrawal and blocks the effects of opioid use, but in the longer term can reduce cravings and can get individuals back to some sense of normalcy in their quality of life. Okay. Now, it is recommended if someone is using an opioid product like naltrexone or buprenorphine, that they should have some sort of alert, like a medical alert card or bracelet or what have you. In the case of emergency settings where, administration of pain medication might be considered, so that whoever is helping to take care of them is aware of that. Now, I mentioned before, there's a couple different ways that opioid use disorder can be managed, and that can be through treatment site, how it's managed, the choice of the medication for opioid use disorder, and of course, integration of some of our psychosocial interventions. Now, for really anybody who has opioid use disorder or has high-risk opioid use, we should be offering harm reduction techniques, which include naloxone and or nalmefene for opioid overdose reversal. So some people might, be in a space in their opioid treatment where their tolerance has reduced and they relapse for some reason, or they were in an abstinent environment, or, various things can happen. So if there's a risk of exposure to opioids, having a reversal agent is a great form of harm reduction. So individuals can undergo induction and treatment on the outpatient level. They can do outpatient for more of an intensive or partial hospitalization. IOP, or intensive outpatient, is usually like an evening type program where they're there for several hours later in the day. Partial hospitalization is usually like a full day, 8 to 3, 8 to 5 kind of intervention where they come in the morning, they're there for programming throughout the day, and then they leave. There's also things like residential and inpatient where they're in a facility, 24 hours a day for several days to weeks. For our withdrawal management products, we have our buprenorphine, methadone, lofexidine, clonidine, and then other supportive agents. So, for example, medications to help with pain and aches, medications to help with diarrhea and nausea. So those can be absolutely appropriate options to offer. Hydration, those kinds of things to help make the withdrawal process less uncomfortable. Then we have our medications for opioid use disorder, so buprenorphine and methadone, which can be used in the induction phase into maintenance. And then long-acting naltrexone, it's more common than the oral, that can be used as an injection after the individual has fully withdrawn from opioids, so usually 7 to 10 days. And throughout this whole process, just, regardless of how we're managing their withdrawal, where they're managing with their withdrawal, they should be engaged in psychosocial interventions. So counseling, relapse prevention resources, peer counselors, having appropriate resources like transportation to treatment, having, address things like food insecurity, and addressing things like trauma and violence. So that aspect is incredibly important to help individuals be successful when treating their opioid use disorder.